Scotland, and it is great just looking at the chat box as people are introducing themselves to see the range of individuals we have today from all over Scotland. Thank you. So in terms of the Primary Care Access Programme, so this programme really builds on work we've been doing in primary care since March 2018, where we started with the Practice Admin Staff Collaborative. We have progressively expanded the range of work that we're doing. We picked up work around serial prescribing. Under COVID, we did work initially around the ACP work. We also supported the Near Me implementation across primary care in Scotland. And then in November 21, we started to do work around GP access tools. And we then brought all of this together under a sprint methodology, which is very much focused on enabling you at a practice level to look at your local system and work out what are going to be the highest impact opportunities for improvement for you to focus on. So this primary care access programme is a 7-week sprint. And as I say, it supports you step by step through the improvement journey. If you could move the slides on. Be great, thank you. So we start with creating the conditions for change, understanding your team's demand and activity, and then take you through to actually testing and refining some practical changes that will deliver improvements for yourselves as practice staff and for the patients accessing your services. And then we follow that on at week 7 with a focus on sharing to make sure that we're capturing your learning, sharing it across your cohort, but also that we're able then to share learning more broadly. And that's very much the theme of today's webinar. So over the past 10 months, we've had 78 teams. And if you could move the slides on, that'd be great. 78 teams participate in the programme. And this is a breakdown of how many teams have participated from each health board. So again, we've got great representation across the vast majority of Scotland. I think looking at that map, we still just need to get Fife and the Borders to get complete coverage of Scotland, but hopefully they'll be coming soon. So finally, just to give you a visual overview as to what those teams have worked on, so you'll see here the split of the focus between appointments, administrative processes, prescribing, and then there are 2 teams that were working on other clinical issues. So hopefully that just gives you a broad overview of this work. We are now going to move on and start our focus by hearing a bit more about the work around appointments. So we have 3 presentations for this session. There will be time for questions after the 3rd presentations. So please do post any questions you have in the chat box as we go along, because it's too easy to forget if we just wait till the end. So please do post. And these will then be picked up later on in the discussion session. So the first presentation, I'm delighted that we have Dr. Lindsay Burgess joining us from the Braids Medical Practice in NHS Lothian. They were in cohort 2, and they will be speaking with Adeline Tan, who is one of our improvement advisors in the iHub, who is standing in as their coach, as their actual coach, Gareth Fitzgerald, is away actually supporting a PCAP cohort 4 event. So Lindsay and Adeline, over to you.
Thank you so much, Ruth, and good afternoon, everybody. And hello, Lindsay. Thank you for coming onto the webinar and sharing a little bit about what Braids Medical Practice have done in the PCAP program. So tell me a bit about your practice and why your team have joined the program.
Yeah, so we're a practice on the south side of Edinburgh. We're about 10,000 patients, relatively affluent, fairly well-educated population. We're a training practice. And we joined really, there was a fairly strong encouragement from the locality and also quite a lot of interest from Jackie, our business manager, who's also on the call today, and our office manager to get involved.
How did you decide as a team what to focus on and what was the aim of your project?
Yeah, so I think like a lot of practices across the board, we were just struggling with high demand, high expectations for care, and really a very limited and finite capacity. We were still doing quite a high volume of phone consultations post-COVID, and we perceived that really was resulting in double working. Patients were also kind of commenting on the lack of a advanced bookable appointment. So we'd spent a few months going back and forth on this, looking at what changes we might make. Plan to sort of make some changes in the new year, but by being involved in PCAP, it really allowed us to evaluate those proposed changes more fully. And our aim specifically was to increase our capacity by reducing that double working. By that, I mean that we would speak to someone on the phone and then we'd still have to see them face to face, which then took up 2 appointments. So we would reduce that double workload by switching to more face-to-face appointments. And we also added in more of the advanced bookable options at the same time as well.
Great. So that was the change idea that you've been testing. And have you been using any measurement tools to help collect your data?
Yeah, so we use the demand navigation tools and the data tally charts to start with. We did 2 sort of data collections, one with the GPs regarding workload, which was very much, was the phone call that we dealt with appropriate to be dealt with on a phone call, or would it have been better as a face-to-face? And we tallied up whether it needed an urgent face-to-face soon or further in advance. We also did a little bit of work with reception about whether they were able to book the kind of appointment for the patient that they thought the patient needed and that the patient wanted. That was a wee bit trickier. We didn't quite get the tool quite right for that one. So I don't have as much data for that, but those were the main tools that we used.
Thank you. So with the measurement that you've done in your data collection and you've tested your change idea, has the change lead to any improvement and any kind of benefits or impact?
Yeah, definitely. So we did the initial data collection before we implemented the change. That showed that about 25% of our phone appointments resulted in requiring a face-to-face appointment, which was a necessity as for that consultation. And that was at the start of the change. And then when we implemented the change, that switched to only 14% of the phone appointments needing a further face-to-face. We haven't re-looked at that, but the general feeling now is that it's much more satisfactory.
That's great. So in terms of, your team's feedback and your feedback, what has worked well for your team and what were the enablers to help you to make the change?
Yeah, so everyone was on board, and I think like most practices, everybody, or reception team and clinical staff alike, we were just feeling that pressure. So everyone was on board with the change. The simple tally chart was by far, we've done lots of QI projects in the practice, and this was one of the simplest ways of collecting data that we've done for a while, and that really kept everybody on board as well. And the reception staff really felt that they loved the changes that we put in place because they thought it was so much easier to offer the patients the appointments that they really wanted. And anecdotally, because we'd started to offer more advanced booking, there was much higher levels of patient satisfaction. That wasn't formally assessed, but was every time patients came and sat down, I'm so glad I could see you, doctor. So that was good.
That was great. Have you come across any barriers, any challenges, and how did you overcome them?
Yeah, well, interestingly, our DNA rate went up. We never used to have a high DNA rate. I think people kept forgetting they'd pre-booked an appointment. It was a bit of a novelty for the last 3 years. Like I said, we'd have a wee bit of difficulty collecting the reception data. We sorted that out afterwards, but it made it difficult to compare. And then the third thing was just that patients really like phone appointments, particularly our population. They didn't like to have to leave their workplace. And it took a bit of time to re-educate that actually there are things we need to see face to face and we can't deal with everything on the phone. So that was a bit of a challenge, but the reception team have really got on board with that and have the things that they know to say, and that's really helped.
What would be your top tip for future interested teams who might want to come and join the program, and what advice would you give to them?
I would say three things. The first is team buy-in is really crucial. It was the thing that kept this project moving forward. And easy tally charts for data collection, again, it just makes it so much simpler. And do the research. You know, we've done quite a bit of research, get good baseline data, because if you've got good baseline data, it really helps you to make those decisions about what your change ideas are going to be.
That's fantastic. So Lindsay, before we end, would you want to tell us what you plan to do, or what have you done since finishing the PCAP program with us?
Yeah, well, fueled by just this kind of experience and ability, our admin team have subsequently looked at our phlebotomy waiting list. We just had a crazy phlebotomy waiting list, and they used the very similar data collection methods to assess where the problems were lying, and then we're able to restructure the appointment template and implement changes which have really helped. So it's just been very enabling to have gone through this process as a whole team.
Thank you so much, Lindsay. And we're in the middle of developing a brief insight with Breaks Medical Practice. So we'll look forward to just publishing them and sharing your good work even wider. Thank you so much. Over to you.
That was fantastic, Lindsay. Thank you. And it is great to hear how it wasn't just a one-off, but how the practice team is now taking the approach and building on it and continuing to apply it. We couldn't ask for more. Thank you. So we're now going to turn to Park Terrace Medical Practice from NHS Forth Valley. They were part of cohort 3, which was our most recent cohort. Jacqueline Rickard is the practice manager. We're delighted that she's here today, and she will be speaking with Alison Serran, who is one of our senior improvement advisors, who again is standing in for this practice's coach, who is Anu Jasal. So this presentation is going to give us a deep dive into how the team worked with their coach to understand their system and identify their change ideas. Over to you.
Thanks, Ruth. And Jacqueline, thank you so much for joining us today and sharing a bit of what you've been working on. As Ruth says, it's kind of a bit new to me as well, so I'm really looking forward to hearing a bit more about how you've been working on it. But can you start by just telling us a little bit about your practice and what made you want to join the PCAP programme in the first place?
Okay, good afternoon. I'm Jacqueline Rickard, Practice Manager at Park Terrace Medical Practice. We're based in Stirling within Forth Valley. We have around 7,500 patients. We have 6 GP partners working alongside a multidisciplinary team, including a practice employed advanced nurse practitioner. We felt it would be really productive to join PCAP for a number of reasons. One, you know, the fact that you have an experienced coach, I think is invaluable, really to support us through the process, using skills, tools and new techniques. Felt that has been really valuable.
Fab, thank you. So when you first joined the programme, I guess what were your initial thoughts both about the process and about what you might want to work on with us?
Yeah, I think the initial thoughts were probably like most general practice, you know, it's busy, how are we going to achieve this? What do we need to do? How are we going to be able to have time over the 7-week sprint? But I think once you get over that, you then start to focus on what you need to achieve, you know, to get the required outcome. And having your project team is really helpful, because then you can start to, you know, idea storm and then look at what tools you need to process what you're looking for. Our focus was obviously the appointment system, which we can talk more about as we go through.
Great, thank you. Yeah, so it'd be great to hear a bit more about where you were with your appointment system and what you were kind of thinking might need to be different.
Okay, so in October 2022, we'd already done some data collection around our appointment system. I've been here for just under 18 months, so part of obviously a new practice manager's role is really looking at, you know, what's in place already. So myself and one of the GPs and deputy practice manager had already done an audit, and we had implemented some changes back in October 2022. When the offer of joining the PCAP scheme came, it was perfect timing because we're at the 6-month review stage. And that was, you know, a big factor in joining the programme. just to help us going forward.
That's great. So you're kind of able to start building on some of the work that you'd already done yourselves.
Yes.
So when you got started, you obviously working with Anu, started to think about how you were going to understand where you were at and what you might want to work on. Can you tell us a bit about the data you collected to try and see how things were at the beginning?
Yes. So initially, when we'd been looking at our appointment system, we could see that you know, we had a lot of work on the duty doctor. And our triage was full, and we're trying to work out how do we move forward. So the first thing we did was we did comparing of appointment types. So the reception team collected data on types of appointments requested versus what the patient accepted, because they can be quite different things. And we also asked the reception team to give their judgment on what they think should have been allocated. Because obviously when you're working in a multidisciplinary team, not everything has to go to the GP or the ENP, etc. So we did, this allowed us to compare the data, and we could see that we really needed to look at more triage. Okay. We then asked our practice employed advanced nurse practitioners to gather retrospective data over a month from EMIS to look at the reason for the triage, was the patient seen by the appropriate clinician, and also the timescale of when the appointment could have been dealt with. For example, same day, 1 to 2 days, within a week, 1 to 2 weeks in routine. And the data did show that the majority of patients reviewed were appropriate for the ENP, but did not always need to be seen the same day. And some of the more chronic and complex patients were ending up with the ENP rather than with the GP. So I think that overall data was really helpful to see, you know, the patient's journey from when they phone to when they're seen. So yeah, that was really, really helpful to allow us to shape what we wanted to do going forward.
Great. It sounds like you did a really deep dive into your data and were able to really understand some of the things that are going on.
Yes, no, it was good, and I think, I mean, although it's I think when you invest in you have to invest the time, you know, to make the appropriate change. So I think it was definitely worthwhile doing that.
Great. And obviously, since you were in our kind of most recent cohort, we know you're still in your testing of your change now. But can you tell us a bit about the change that you identified and what it is that you're testing at the moment?
Yes, I can. So we only started the testing stage actually this week. So only started yesterday. So we are very much in the early days of the testing stage. We have changed what the advanced nurse practitioner does. So they worked a timed list and also appointments in the morning and the same in the afternoon. So what we've done is we've taken away the timed list, and they've got a purely just a list in the morning so that they can manage their workload. There's no appointments in the morning now, and we've increased the triage by 25% in the morning.
Oh.
We've decreased appointments by 16.5% in the afternoon. Now, obviously, we'll have to see if that's going to work. But the idea is that we do know that we needed to offer more triage. And that, you know, through discussion with our practice employed ENP, she felt that this is, you know, that this would be manageable. So that's what we've started to do. So we've went away from a timed list, because the problem with a timed list is if it's past that time, then it's a wasted appointment or a wasted triage.
Yeah.
So we're working to a morning list, and the ENP can then manage that at whatever time they want to phone the patient back, and then in the afternoon they have appointments. And obviously we factor in admin time for that.
That's great.
Yeah, we're trialing it, and we'll see how it goes.
Yeah, and we'll really look forward to hearing how it's going. We're just about out of time, Jacqueline, but can I just ask you, do you have one piece of advice you would give to a team who wanted to work on something similar?
Yes. Excuse me. I think just to get the right balance within the project team, and the right skill mix is really crucial as well. And, you know, open communication. Make sure that you know, involve all your team and get them on board. And we also produced guidance notes as well, just so they had an aid memoir so that they knew, you know, what was going on in advance of the changes happening.
That's great. Just keeping on top of those communications, making sure everyone knows what's going on.
Yeah.
That's
Yes.
fabulous. Thank you. Thank you so much for talking to us about your
No
project.
problem.
today.
Thank you so much.
Thank you, Jacqueline. Again, that was just another great example of practical work taking place. So lastly, in this section, we are going to move on and hear a recorded presentation from Midlock Medical Centre, which is based in NHS Greater Glasgow and Clyde, and they were in cohort 2. So this presentation is by Andrew Moore, the practice manager, and Maeve Gilsenin, the GP. Gareth Fitzgerald was the coach supporting their work. So play away.
I'm Andrew Moore, I'm practice manager at Midlock Medical Centre, and I'm joined by Maeve Gilsenin, one of our GP partners here at Midlock. So we are based in Ibrox in the southwest of Glasgow. So there were quite a lot of different things that we looked at originally to change or to review. But a collective decision was made, I think, not long after on one particular work stream within the practice, which was our triage. And just to give a bit of background on how we work and how that model works, we have a triage system in the practice, and a GP each day is allocated to oversee this triage column essentially, and it's a telephone triage column. Systems in place for patients who require on the day urgent assessment, who feel that they need seen that day. It's open from the minute our phone calls go over each day at 8 o'clock in the morning, and it closes, or did close, when the phones went over again at night at 6 p.m. So it was open pretty much Monday to Friday for 10 hours a day at a time. The GP normally will consult with patients when they're added to the triage list, and if a face-to-face appointment is required, they would then allocate that patient to another GP who had reserved face-to-face appointments each day that was ready to be booked for the triage GP for making any follow-up face-to-face assessment. I think it's important just to say that the system was created pre-pandemic, and so this had actually already been our model for a number of years, I believe, wasn't it? So I think over time, triage kind of has become littered with things that could be dealt with probably by another healthcare professional, or probably wasn't suitable for urgent on-the-day assessment. So, you know, as Maeve says, this has resulted in a big workload for GPs, but also the wider practice team. And I think that's what we wanted to look at, was how we manage that sort of moving forwards. So what did we do? Well, we had a fair idea that that was the biggest demand that was coming in every day from our patients, was that they were wanting to speak with a doctor that day. And we did a 5-day audit just when we began cohort 2, which showed the highest request each day from patients was for a same-day triage call from the GP. That was unsurprising to us, because you can visibly see that on the appointment screen, and every name just goes in one after the other on this column.
Yeah, try to figure out maybe a cohort that the girls would be able to identify easily and offer the face-to-face appointment that would generally be appropriate. And we came up with children. We have a low threshold for seeing children, as I guess most GPs would have. If a parent rang in the morning and said that the child was sick, they would most often get seen face-to-face. So we came up with the idea that children aged 8 and under would get a face-to-face appointment booked in directly by the admin staff, unless it was something very simple, and they could be signposted to the pharmacy or other kind of routes.
So over those 3 weeks, there were 63 patients in total who were 8 and under, who had then been booked direct in for a face-to-face appointment. Feedback from the GPs was that 61 out of 63 of those appointments were appropriate for a direct face-to-face appointment, and had they been doing triage, would have asked to see them in practice anyway. So from that, we knew it was working well, and as Maeve said, it took a chunk out of the triage. We removed a fair bit of duplication there, but we wanted to also just get feedback from the staff and from patients as well. And overall, the reception team, I think, felt a bit more empowered, had a bit more autonomy, and been able to offer something a bit different. But actually, it was a positive change as well. Patients felt more reassured that they could be given a specific appointment time, and they knew when to come to the practice. From there, we decided to build on that and I think look at other cohorts or groups of patients that would be suitable for admin staff to book in at their level again. And we decided to look at patients who maybe call and present with lumps and bumps. I think we'd looked at, or we did look at breast lumps, testicular lumps, painful testicles, things that we know again, if they land on triage, they're going to come down anyway and we're going to assess them. So we sort of communicated that with our admin team. Anybody that presents with these symptoms, we get in directly face to face. And we are continuing to do that. That again seems to be working well. So I think we're just sort of starting to build on these things where we can start to book more things in face to face. We also wanted to look as well at our triage times because, as I mentioned earlier, our triage pretty much opens at 8 o'clock and closes at 6. And what was interesting for us when we were doing PCAP and when we were doing our meetings in PCAP, having spoken to other practices, it became evident that we ran ours far too long compared to some other practices. So we've decided to scale the triage back a little bit as well, but we felt we wanted to do this early because I think out of some of the changes that we made, this probably brought around the most anxieties. People probably worried a bit more about doing that because we've never done it before. So I kind of picked a random 2 weeks in January of calls that were coming in sort of late in the day. And I picked up on 37 calls that come into triage after 4:30, by which point most of the face-to-face appointments for that day had gone. And of that data, it showed that the last of the triage calls were finishing generally around 5:30 onwards, and in some instances close to 6 o'clock and after 6 o'clock. And in some of these instances, patients were being brought down after hours for face-to-face assessment and were essentially added into an extra slot. So from that, we've decided to scale back on our triage times and closing off at certain points in the day. So again, we took baby steps with this because we didn't want to overwhelm too many people. But before we did this, Mayview sat in reception for one morning and we had another GP sit in reception. I think that was quite a good exercise before we done this. My advice is to form a group and crack on with the changes and communicate it back to your teams and who it's going to impact. And so I think for us, we're definitely going to move forward and make more changes.
Thankfully, it has really worked for us, and that's given the rest of the GPs confidence and thinking us making more changes, which ultimately is a really good thing. But yeah, we picked a really small change, you know, seeing 8 years and under, getting them pre-booked appointments. And then the next step kind of came out of us having a group meeting and suggestions from our other participants in the PCAP. So it was kind of like a two thing that we did in this cohort.
So I'm Andrew Moore.
Great, thank you. And thank you to all of the teams for presenting. So we have 5 minutes for questions. I know quite a few of the questions that have been asked have already been answered in the chat box. So thank you for those who've been leaning in and doing that. We're not going to go back over those ones. But Adeline, do we have any? I think we do have a couple of questions that have not yet been answered, and I see ones are now coming in as well.
Yes, we do have. Fiona was asking that she's interested in the practice's definition of triage. Do you mean on the day telephone consultation / callback, or are there other definitions of triage?
We have someone who could answer that. I think that might have been aimed at the Matlock practice. Oh, Scott, thank you. You're rescuing me. Thank you. You might be muted, Scott.
Yes, I am. It's one of so nice to see you all. I'm Scott Jameson. I'm a GP. I'm also co-chair of the GP Access Review with Fiona, and it's one of Fiona's bugbears, and she's absolutely right that triage is a process by which you determine a timescale for somebody to be seen. Telephone consultations are a way to have an interaction and management with somebody. So often the terms are used interchangeably, but they are meant to be distinct different things. So I think Fiona's right to point out and highlight that it's great to make sure that when we say triage, what we're meaning is just a process by which we determine when somebody's seen. Telephone consultations are actually, managing somebody by telephone, and that's not quite the same thing. So it's important that when we say we've got a triage model, well, that's a model to determine when somebody's seen. If we do offer telephone consultations in the first instance, that's a model by which you're managing patients. So it's to make sure that we don't get cross wires. And so Fiona's asking to try and unpick and make sure that she doesn't misunderstand the model. So hopefully that clarifies that. So there you go, Fiona. Hopefully that helps with them. So no, but it's a good point from Fiona. She's absolutely right. And it does come up quite a lot. So yeah, be careful what we mean by triage versus telephone consultations.
Great, thank you very much, Scott. And just to encourage you to keep, if you've got questions, to put in the chat box, but also if you've had a light bulb moment from any of these presentations that you can apply in your own workplace, then please do let us know in the chat box. We'd love to hear. And also if you've similarly made changes in your area on the same topic that you'd like to share. So Adeline, are there any other questions?
Yeah, so this question came from Scott, but it's directed at Midlock, and because Andrew and Maeve are not here and Gareth's not here, I'm not sure if we can answer the question at this point, and we might have to come back to Scott once we go back to Midlock and Gareth. So the question was, how many kids less than 8 years of age were previously seen face-to-face, and whether was it 97%, which Scott thinks it is, but I think that's the baseline. And also how many people still seeing females aged over 65 years old that are not navigated to pharmacy.
Yeah, it was just to, just to make sure that they, so if I was going to go back to their baseline, the baseline is how many they did before rather than, their starting point. But the other thing is just about that care navigation bit as well. So if anybody does have that model where they're doing kind of a duty doctor or a duty ANP system, one of the big investments you can make is good care navigation, which of course was a previous collaborative as well. So care navigation before you even get onto that list is really, really worthwhile. And if you don't know how many of your calls are being navigated to other outcomes, assess that and try and improve it. We've improved ours by, I'll maybe bug it in the chat if I get a chance, but we've got like a list of all the care navigation options for our practice so that our admin have that at their fingertips and what the inclusion and exclusion criteria are, and that massively can bump up the amount of things that are navigated to other call outcomes. And it's been something we've done as a cluster, and it can massively improve the number of things that are navigated elsewhere before they even get onto that triage duty person list. But triage is a foul word there, Fiona. Look, even I have slipped into the incorrect use of it. So I'll stop talking before I get into trouble from Fiona. Get my knuckles wrapped.
Thank you, Scott. And we've got time for one more question, and I'm going to suggest we take Graham Longairs, who is asking about any patient education info to accompany the access changes. Great question. Do we have any patient education info? Fiona. Again, Fiona, you might need to take mute off. Or we may need to unmute Fiona.
That's you. You should be able to unmute yourself now, Fiona.
Right, sorry about that. Yeah, as you can actually see me. As Scott said, I'm joint chair with Scott of the General Practice Act.
Fiona, you're very quiet. I don't know, have you got a headset? Can you pull the...
It's because I was having my lunch while I was watching it. So yes, as Scott said, him and I are co-chairs of the General Practice Access Short Life Working Group, working on principles around what does good access to general practice look like. We have been working with his community engagement team to get the patient feedback and patient voice around what patients want or would look for from what good access principles would look like from a patient perspective. We will be publishing those principles in the summer, and we're also looking at easy read versions of that for the public and various other versions of that to help the public understand that. But I think one of the things that has come out from that community engagement work has been things like the public don't understand things like care navigation. What does that mean? They don't understand why receptionists are asking them for some general information. They think they're just being nosy little busybodies that are trying to stop them getting access to the care that they want, all of those kind of things. So I think there is work that we need to think about how we support and educate the public around how general practice is working and the wider system and how complex it is now. But I think it's on all of us to do that. But I think language and consistency of how we do that is really important. So it's something we're very mindful of around that access work and the access principles, and definitely a lot for us to do. So anybody got any ideas or thoughts around how to do that after we've published the access principles, then please come back to Scott and I around that.
Great, thank you, Fiona. And I'm so sorry, but we're out of time. We need to move on to the prescribing session now. So any other thoughts or responses around any of that, please do post in the chat box. So we are now going to move on to our prescribing section. We have one presentation for this, and it is a recorded presentation from Carrick Medical Practice, who are based in NHS Ayrshire and Arran. They participated in cohort 1, and Stacey Ross, the practice manager, will be presenting. Fiona McGeer was their coach and will help to answer any questions. So over to you.
That's fine. So we're Carrick Medical Practice in Maybole. As myself, I'm the practice manager. Dr. Chaitanya Mudanuri, and also our admin team leader, Nicola, was involved in the initial discussions that we were having. So what we realised that, you know, there's a problem with acute prescriptions that just kept you know, where acute prescribing column was just huge every day, a huge number of acute prescribing, and like what we did was we looked at STEW data, put the data onto the Pareto chart, on the oh sorry, next slide. I'm not used to this. So what we did was we looked at STEW, we put the data onto like the Pareto chart, and it was no surprise to find that our like biggest acute prescribing was antidepressants. So we decided to have a look at what our current process is and how we could potentially improve it. Next to antidepressants was endocrine test strips, lancets, etc. So we'll look at the acute prescriptions. So ready for the next slide. So what we did was we looked at our current process flow and found that what we were doing was the antidepressants were put onto acutes. Patient would call up again. Just this like vicious circle of the antidepressants being put on acutes, patients not turning up for reviews when they're supposed to. So our way around this was to, rather than putting them onto acutes, we decided that it might be better to put them onto a limited repeat with an issue of 1. So an issue of 1, the clinician gives the patient their prescription and tells them to make a review appointment in, you know, 3 to 4 weeks time. Patient comes in, sees clinician again, and they then get another limited issue. You know, they're getting continuously reviewed. That review period could be made longer, depending, you know, they could maybe get 1 or 2 or 3 more issues, and then so on and so forth. If the patient is to continue and be stable, then there's potential for it to be put onto serial prescribing, or CMS as we all know it. So that was our review. So we developed a protocol as well for all prescribers and all staff. But admin staff were involved as well. They're allowed to move some items. This is where our like diabetes, you know, like lancets and things, if they see them on acutes, they move them over to repeats. So that's working well. So the things that was all the ideas we had. So that they're working well just now. So like what worked well was like we knew what we had to do. We involved the whole team, because you just need wee snippets from everywhere. You know, your girls that are taking the prescriptions, your clinicians that are doing the prescriptions, your pharmacy team, we're a mental health practitioner as well, who's also reviewing patients. And as I say, we mapped the ideal process. which does need reviewed again. So so the stuff that enabled us to do this was the STEW data, enthusiasm from the whole practice team, because it wasn't sustainable how we were currently working. Communicating to everyone, what we're trying to do and what our end goal is, and also another thing that helped us was we're doing a medicines management project that Ayrshire and Arran do every year, so that's kind of fed into this area of work as well. Ready for the next slide. So the challenges that we've had, obviously workload pressures, not everything runs like clockwork all the time. We've got additional staff in, like locums, that maybe have been used to doing something one way and maybe not following our process. But we've overcome these challenges by just everyone doing their bit, sharing the workload, having weekly conversations, just how we can do better, and just like sharing the process with everyone. So like top tips are just basically we're just, what we've done is, it's a small change that we've made, but hopefully it's going to make a bigger change. And same, we've not looked for a huge difference, but hopefully what we're going to do is going to make a difference in the next few months, hopefully when everyone gets onto serial prescribing. So that's kind of it, really. So we're still getting there, saying, but I think weekly reviews will, and small changes. So yeah.
Thank you very much, Stacey.
Great, and some of you may have noticed in the chat box that Stacey has been able to join us, so she is available to answer questions. We're on a very tight schedule today, so I'm going to take Chair's prerogative and move us on to the admin session. And then if we have time after this presentation, we will pick questions up about both this and the prescribing one that we've just heard. But please do also all use the chat box. That is working really well to get questions asked and answered in a very efficient manner. So the final team is the Graham Medical Practice from NHS Forth Valley. They were part of cohort 2. And Gillian Campbell, practice manager, will be speaking with their coach, Alison Serrin, who is a senior improvement advisor. So over to you.
Hi, sorry, it's Lynn. Gillian's sidetracked here because it was me that did all the work for it.
No problem, no problem. Good to see you. Thank you for joining us.
You're welcome.
I'm just going to launch right in and ask you a few questions about the project that we worked on. So first of all, can you just tell us a little bit about the practice and kind of how you came to join the programme?
We are one salaried GP, 3 partners, practice manager and 6 admin. And we came to the programme, the doctor put it forward, thought it would be interesting, and we weren't too sure of what was happening, as you know, at the start. And I think Gillian had put down our workflow as what we wanted to work on. But when we did the initial meeting and listened to everybody else, we thought, no, that's not what we want to do. So we found the problem was I found that it was the phone calls coming into the practice, and we were using too many reception staff to deal with the phone calls. So we used your programme to do a survey and find out what everybody was calling in about.
Yeah. So we collected some data about what the different kinds of phone calls, and what do you think we got when we looked at that?
Well, we found that the majority were either looking for, or we checked out whether it was urgent appointments, routine appointments, nurses appointments, and any queries that was coming in. And I think they said about sick lines and prescriptions. So we found that was the bulk of what the calls were about. And we did the survey and collected all the data, and we had all our graphs, and decided to pick one that we would work on. And so we decided to pick sick lines.
Yeah.
I think it's small. Was the
Yeah, so
best
we
way to
decided
go.
to start small, didn't we? So
Yeah.
and I have to say that you and Gillian were did a really great job of coming around to being in the program when you'd basically been nominated by someone else and didn't know what was happening at the beginning. I remember when we first met, but we were able to get started and do some work. And so we picked out the fit notes as a kind of small but manageable thing to work on, didn't we?
Yeah.
And especially because a lot of those calls were coming in the morning when you should have been having your phone lines ready to free up for urgent appointments.
Yeah.
So so we did a bit of work to map out those processes.
Yes.
And then do you want to tell us about the change that we came up with to?
The change that we had come up with is when they dedicate an email address, so that when they called in, we would inform them that we were making the changes, and if they wanted to email a request in, so that they could do that the evening before the morning at their better time scale than having to try and get through on the phone. And if we put it across that way, that they're not on the phone line waiting. So we had dedicated a email address and informing the patients of that. And we would do the checks at the time when they requested. So if they had given all the details, and then we'd check the notes if they had to make a review, and then we'd email them back to say you had to make a review or your request was forwarded to the GP and would be available for collection whenever that was decided. And all the information was given to the GP without any queries coming back. So that kind of cut out them back and forward. Oh, you've not said this, or they had to review the last time. They need that done. So it was a bit easier, and everybody seems to be on board with it and happy with it so far. Patients, GPs and reception.
That's great. That's really great to hear. So can you tell us a bit about how you've sort of looked at the impact of that? I know you've collected some data to see the change.
I didn't have it in front of me. I'm just
no, that's okay. Just tell us about how you did it.
But so we implemented it for about a month, I think it was, and then we did the data again to see how many calls were for sick lines and how many were email requests. And I think it was maybe a quarter, not even that many phone calls, and most of them were the emails. That they were a good chunk of that, so that was the best thing that we had.
They look great. So I think it was after a month it was about a quarter, and then after a couple of months it was basically none. So you basically have no phone calls now.
There is there's just the odd one that they'll say I don't have internet, I can't do this. That's fine, you can either still come in, but at least if it's cut the bulk out, we don't mind 2 or 3, and we still don't say no, but you know, it's let them decide what they want to do, and it makes it easier.
But definitely, if you plotted your data on a graph, you'd see the phone calls going like that and the emails increasing at the same time. Really great. And so, what else do I want to ask you? Have there been any other kind of benefits of the work? So there's obviously been that shift in numbers, but what kind of benefits has that made for your team, for the practice?
What do you mean? Still in the FitNote one, or?
Or you can tell us about what you're doing next if you like. That would be great to hear too.
Well, we kind of really engaged in this, and we took the tools again, and we then decided to have a look at the emergencies, what we class as urgent on the days, and routine appointments. And the urgent on the days seemed to be coming in the whole day. So it wasn't freeing anybody up for routine. They were waiting on these on the day, whoever was on the emergency calls. So we've kind of changed that as well to say that the morning from 8 till 10:30. The calls coming in would be for urgent on the days, and then from 11 o'clock the rest of the day is for routine, and they would be available then, so that then the bulk of the calls and they all come in at 8 o'clock in the morning for everything, and then too many complaints about not getting through on the phones. So we used the data and see if we could do that, present it to the GPs, and they ran with that. We started that 3 or 4 weeks ago. So we seem to be, hopefully, and we sent a text message out to all the patients about the changes, and we seem to be running with it quite well. I think then if they're needing an urgent appointment, they're asking, they're phoning in on time, and they're getting through to get that, so it makes it easier for them, no having to keep trying and then not getting anything.
That's great. And it's really great to hear about being able to kind of go back to that initial data set that we collected and say, right, what's our next step once we've done one thing?
What's next to pick?
Yeah. So one last question for you, Lynn. Is there a tip or a piece of advice you would give to someone else who was thinking about signing up for the programme or thinking about working on something similar?
Oh, try it. You might be sceptical and not understand it at first, but as soon as you hear the first meeting, the cogs start to go and you think, oh yeah, that's so I would just go for it, and it does help the practice when you see all the data and all the numbers in front of you. It helps. But no, we don't look back now. Thank you for all your help.
No problem at all. Thank you so much for speaking with us today. We really appreciate it.
Okay, thank you.
Thank you. And thank you, Gillian, for stepping in at the last minute. We really appreciate that. So we have time literally for just one question, but please do keep using the chat bots to ask and answer questions, and also to post any ideas where you've worked on similar issues and you want to share what you've been doing, or any light bulb moments. So Adeline, do we have a question from either of those last two sessions that hasn't been answered?
Yes, so Michelle asked if there has been any practices that involve patients or patient participation groups in helping to co-produce or redesign, and if they do, how has that worked for you?
Okay, anybody on the call who has done that and is able to give us a brief 1-minute response? No hands up yet. Okay, so that looks like that might be an area where we need to focus some attention. So great question, Michelle. And I know there's that real focus we have now on co-designing. So that's something I think we can pick up after this. I'm sure there are practices out there who have done this, and it might just be that they're not on the call or feeling too shy to answer that one, but we'll see what we can pull together. And it may also be, as I say, an area where we need to do some work. So thank you so much, everyone, for today. One of the things I love about working with primary care is your ability to take something and make it happen at pace. And we've seen so many examples of that today. Thank you. So I am going to now hand over to April, who is going to close this session. April, over to you.
Thank you very much, Ruth. So I am just going to wrap everything up and do a bit of light housekeeping at the end of our session. And I just wanted to pull out a couple of themes, or about 3 themes that I've noticed from today's session. And the first one is, and we do often say this, so sorry if I sound like a broken record, but everybody on this call who has spoken has mentioned the importance of buy-in from your project team, bringing the project team on, making sure there's a good skill mix and also good communication. So that has been a thread throughout everybody's presentations today, I think. And the second thing that I've picked up on from, I think just about everybody mentioned this as well, is the importance of that data collection, again, this is something we talk about a lot in quality improvement, is the idea of being sure that you're collecting data throughout your journey, that you continue to collect data until you're clear that your change has led to an improvement and that improvement has been sustained. So two really crucial points that I couldn't have made better myself from our colleagues who have been working alongside us. And what a wonderful thing to hear from some of the teams is that they've used these skills and the quality improvement techniques that they've learned in the 7-week sprint, and they've taken it and applied it to something else or multiple other projects. It's the kind of holy grail really for us of what we try to do, and that is building capability and capacity out in the system for you to continue to do this type of work. So wonderful to hear from all those teams that you've been achieving those things. So I'm going to move us on, I think, to the next slide and just quickly sort of point out a few different things that you might be interested in. So we have been producing some what we call brief insights. They're like case studies, but more visual and much shorter and punchier. We've recently recorded a podcast around the access work, and we were recently featured in the Scotsman. So we'll include that information so that you can have a look and explore more information about some of the work that your colleagues have been doing alongside us in PCAP. So I think we might have something going in the chat right now, which is just a very quick bit of feedback that we would like you to do. We always want to know what we can do to improve. So please, if you could click on that feedback link and fill in a couple of questions just to let us know how we've done today and whether you would like something improved for next time. And I'm realizing that we've only got a minute left, so I want to say that we are going to send a follow-up email that will include the slides and plenty of information for you that's been included in the chat. I noticed a lot in the chat, so we'll try and pull that together as well. And if there's anything that you want in the meantime, please do feel free to contact us on any of these contact methods through Twitter or email or however. And so just finally, thank you so much to everybody who has taken the time to attend, especially those teams who took the time to prepare and share their learning with us. And we look forward to seeing you on another webinar soon. Have a good day, everybody. Thanks.